And I'm going to introduce Dr. James Davies. James, it's a real pleasure to have you with us again. So James Davies holds a PhD in medical anthropology from the University of Oxford. Hi, James. He's a practicing psychotherapist, a reader in anthropology and psychology at the University of Roehampton, London, co-founder of the Council for Evidence-Based Psychiatry, has published several books, including Cracked and Sedated. I'm sure the links are going to appear in the chat very shortly. And I imagine he's going to do his usual perceptive job of putting some of all this in context. How have we ended up in this mess? What's it all about? And perhaps some thoughts about what we need to do differently. Thank you. Over to you, James.
Thank you so much, Lucy, for the kind introduction. As you were talking, I realised I'm sitting on a very squeaky chair, so I do apologise if you hear. I
can't hear. I don't know whether people can hear.
I'll try and remain as stationary as possible. But thank you so much for having me. I really appreciate the invitation. I presented last year as well, and it's lovely to be in the company of excellent people and many like-minded people as well, both other speakers, but of course people listening in today. So thanks for giving me the opportunity to talk about a topic I feel very passionately about, which is the relationship between political economy and mental health. And that's what I'm going to talk about today. I'm going to just see if I can share my screen. Let me see if that's possible.
So you should have the co-host privileges there, James. So,
okay.
Yeah.
1 moment. Yeah, I'm not sure if I can, for some odd reason, it's not letting me do so. It's not the end of the world. It's okay.
Yeah.
Perhaps I could just present you without the PowerPoint.
Yeah. Shall we, do you want to try again when you hit that green button, as you're not getting the option to share your screen, the green button in Zoom in the middle?
Yes, I am getting the option, but it's not enabling me to share my PowerPoint. So that's very odd. Not happened before.
We've got it now. We can see it, James. So yes.
Oh, you have it.
It's
okay.
Up on the screen now. Yeah, great.
Excellent.
So that's all working. And if it's all right with you, I'll give you a little 5-minute time check when we're just coming to the end. Yeah.
That's superb. Thank you.
Great. Thank you, James.
So just before we start, I just want to let you know, John, that I don't have control over this PowerPoint. I think you do. So I'll ask you on each occasion when to change the slide, if that's okay.
Absolutely. Yes. Thank you.
Okay, good. So let me start. I'm going to start today by presenting a case study as an entree into some of the issues I'd like to raise in the presentation later on. So let me start with the case study. So Emma arrived for her first therapeutic session looking tired, demoralized, and much older than her 22 years. Behind her struggle to project a posture of confidence and strength, her sadness and vulnerability easily came through. This was most evident when she spoke about her 4-year-old daughter, Mimi, with whom she no longer lived. Since Mimi had gone to live with her grandmother, Emma's mood had degenerated significantly, leading her to feel dejected and sometimes suicidal. When she finally visited her GP, he diagnosed her with clinical depression and prescribed antidepressants. He also gave her a leaflet about our therapy service, a small no-fee family-centred charity located in the middle of the council estate where Emma lived. The story Emma told me of her life was harrowing. Between the ages of 9 and 16, she had been moved between 4 different foster homes, living with people whose names she could mostly no longer remember. She dropped out of school at 15, taking on various low-paid retail jobs. She met Mimi's father, Pete, when she was only 17, hoping he would whisk her off to a better life. But this was no love story. Pete soon began abusing her emotionally, physically, and sexually. After about 6 months of enduring this, she became pregnant. But the abuse didn't stop. If anything, it intensified, continuing right through her pregnancy. When Pete finally left her 8 days after Mimi was born, Emma's relief was sporadic, as he would periodically turn up at her flat, demanding money and becoming violent if she refused. The world changed for Emma when one day she fought back. Mimi had woken during one of Pete's abusive visits and was crying uncontrollably in her basket. Pete grabbed the basket and started shaking it violently, shouting for the baby to shut the fuck up. Emma fought frantically to get him off, but Pete was far too strong. Now screaming and desperate, she grabbed a mug and shattered it across the side of his head. As he stumbled back, she grabbed her baby daughter and ran out into the street. The police were called and Pete was later arrested. 5 years after these traumatic events, I began working with Emma in that family centre. By this time, Mimi had now was living with her grandmother, who was actually Pete's mother, under the pretext that Emma's mild epilepsy somehow posed a danger to Mimi. Emma therefore saw her daughter only 3 days a week, but this was not a legally binding arrangement. Rather, Pete's mother had originally offered it as an unofficial short-term measure to help Emma out during the difficult period after Pete's arrest. After 16 months, this had taken on an aura of permanence, even though Emma desperately wanted Mimi back with her at home. A few months into my work with Emma, Pete's mother, for no apparent reason, decided to reduce Emma's access to Mimi to just 2 days. While this left Emma distraught, she feared that if she protested too hard, she'd be stopped from seeing Mimi altogether. She felt trapped, but reasoned that at least she still had 2 days alone with Mimi, days around which her life now entirely revolved. The whole week she would prepare for Mimi's visit. The sheets would be washed and pressed, the entire house scrubbed, Mimi's favorite foods bought and stored. She would even write for each visit a little bedtime story for her daughter and buy a new toy with what little spare cash she had. She and Mimi would stay up late, reading, cuddling, and laughing, while planning imaginary trips they would one day take together. When Mimi would ask, "Mummy, when can I come home?" Emma would struggle to hide her tears. And when the next morning arrived and the little girl was picked up by her grandma, Emma would feel devastated, often repeating the same dejected ritual, retreating to her room and hiding away alone. 6 months into my work with Emma, something decisive occurred. She took the step of speaking to a community solicitor about her situation with Mimi, something I'd encouraged. Soon the solicitor and I were working together, eventually through the courts, to increase Emma's contact time. After a protracted struggle, the court declared that Mimi was entitled to live with Emma for 3 days a week, with a view to eventually moving in full-time if all went well. As these changes were gradually implemented, the effect on Emma's mood was remarkable. Her entire demeanor transformed, new hopes for the future were kindled, and her self-esteem and confidence visibly increased, not least because she experienced the court's verdict as a validation of her as a mother. After my work with Emma eventually came to an end, every once in a while I would hear from her until the spaces between her messages gradually stretched out into silence. She told me that she and Mimi were doing well. Mimi was now living with her largely full-time and was enjoying school. Emma herself had enrolled at college part-time to train as a nurse. Now I recount Emma's story here because it illustrates something that I, as a fledgling therapist back in the early 2000s, had not expected to encounter when I started working in my very first therapy placement. That the vast majority of people coming through our doors were not mentally ill or dysfunctional in any substantiated biological sense. They were rather people experiencing the inevitably painful human consequences of being engulfed by life's difficulties or severe misfortunes. This is not to diminish their suffering in any way, nor to deny that they deserve care and support, as Emma evidently did. It's just to say that I learned early on that reclassifying understandable human suffering as mental pathology, for me, had almost no clinical worth, especially as such framing enjoyed no robust evidential backing and often distracted from taking the psychosocial determinants of distress seriously in any clinically relevant sense. I have told Emma's story because in many basic characteristics, it mirrors the stories of most people I encountered in that family centre. Like her, the majority of people were living with very difficult situations, and yet most also experienced having the human and social causes of their suffering largely ignored. Instead, like Emma, after a 7-minute GP consultation, many ended up being prescribed with psychiatric medication, which most took for extended periods, while nearly every one of them had been given some kind of label, like a depressive or anxiety disorder. Yet for most, just like for Emma, there were fathomable reasons as to why they suffered as they did. And these had nothing to do with having a so-called mental illness or a chemical or dysfunctional disorder. Far from being pathological reactions in otherwise happy lives, they were suffering from sane human reactions to factors like social disadvantage, marginalization, poverty, trauma, social discrimination, dislocation, to legacies of abuse, social neglect, denied opportunity, and so forth. Despite such suffering being invariably caused by complex socio-political, interpersonal, and psychological factors, it was still invariably and only medicalized and medicated, and on far too many occasions, in my view, to ill effect. In those early years, I constantly asked, how did this wide mismanagement of our suffering come to be? After 12 months working in that family centre, I took on a second clinical placement, this time in an outpatient psychotherapy unit within the NHS, where therapy could be given for up to 2 years. The clinic was set in a far more affluent part of the city, serving a mostly white, middle-class, well-educated and financially secure demographic. But here, the suffering I encountered was no less real or immediate. There were relationship problems, sexual problems, unhappiness at work, low self-esteem, thwarted ambitions, bereavement, loneliness, meaninglessness, and ennui. Most people, once again, had been prescribed psychiatric drugs, and most had been given labels that dressed their suffering in medical terms, anxiety, depression, and sometimes more severe diagnoses, bipolar, personality disorder, or psychotic disorder, schizophrenia. But here too, I never met a single person I felt comfortable calling mentally ill in any biologically verifiable sense, even though most of their understandable yet painful experiences had been recast as symptoms of various disorders to which various drugs had then been matched. Working on the front lines in mental health services is an instructive experience. But the most striking lesson I learned in those early years was how little time there is available in our mental health sector to understand the lives of the people who seek our help, their work life, their home life, their early life, the circumstances and relationships in which they are deeply embroiled. On the occasions when time and attention is allowed, professionals at least have a chance to work towards a meaningful and shared narrative of why a person suffers as they do, one that can give meaning and hope and inform what specific changes can at least be attempted with ongoing psychological and ideally social and financial support. During this process, if all goes well, a confiding, trusting and facilitative relationship may also be established, which we now know to be a very important factor in aiding any person's recovery. In short, the very things most likely to bring good mental health outcomes, enduring and facilitating relationships that increase understanding and hope for recovery, are the very things most lacking in the services charged with our mental health care. What I've just described to you was the state of affairs in the early 2000s when I first started working as a psychotherapist. But you'd be mistaken to think that since that time, change has tended in a positive direction. You'd be mistaken because in many important respects, the situation has got far worse. Not only in terms of the availability of long-term post-6-month psychotherapy or counseling, which has almost become non-existent in our mental health services, but in terms of the general clinical outcomes we have witnessed emerging across our mental health sector. To illustrate this last point, please consider for a moment an analogy that the eminent clinical psychologist, Professor Richard Bentle, once drew in relation to our clinical outcomes data. He said the following: if as a child in the 1970s, they contracted leukemia, their chances of survival were around 20%. But if a child today contracts leukemia, their chances of survival are around 80%. This means that outcomes in this area of medicine have improved by a full 30% in the last 4 decades alone. And this wonderful feat is not only reserved for pediatric oncology, since impressive rates of improvement can also be found in almost every other area of medicine. I say in almost every other area, as regrettably, there is one exception: the area of psychiatry and mental health. Sadly, in this area, the area in which I work, not only have clinical outcomes broadly flatlined over the same time period, but according to some measures, they've actually got worse. For example, the effectiveness of psychiatric drugs has not increased since the 1980s, despite billions spent on marketing and research. At the same time, mental health disability rates have almost trebled in recent decades, while the prevalence of mental health problems has risen steadily, despite levels of general well-being in the community not necessarily getting worse. Furthermore, for people diagnosed with the most severe and serious forms of mental health problems, the gap between their life expectancy and everyone else's has widened from 10 to 20 years. These dire statistics exist despite our having invested over £250 billion in UK mental health services and research since the 1980s. And despite nearly a quarter of our adult population receiving some kind of mental health intervention in any given year, and granted that quarter are most of that quarter are receiving psychiatric drugs and little else. So why are mental health outcomes in such disarray? Well, that's the question I've been studying for many years. And to cut a long story short, one of the things I have arrived at, one of the conclusions I've arrived at as to why outcomes aren't improving, is because since the 1980s, our mental health sector hasn't really evolved to put the needs of its users first. Rather, it's progressively evolved since the 80s to put the needs of our economy first, our late capitalist or neoliberal economy. And it's the mental health sector's adaptation to the needs of our economy that I argue has come at the expense of those in most need of help and support. So how has this adaptation of our sector worked? What are the mechanisms that have enabled it to become a handmaiden of neoliberalism? Well, the mechanisms I explore in my book are dynamics such as medicalization, pathologization, commodification, individualization, depoliticization, decollectivization, etc. And as a course, I can't cover all of these mechanisms today. Let me just consider 3 in order to illustrate how these mechanisms have, on the one hand, enabled this sector to continue to thrive and dominate during the neoliberal era, despite its not delivering on clinical outcomes. So the first mechanism I'd like to discuss, and if you could change to the next slide, please, is medicalization. The process by which our mental health sector has increasingly pathologized our emotional, behavioral, and mental lives. So, as many of you may well know, since the 1980s, under the control of the psychiatric profession, our sector has progressively renamed more and more of our natural and normal, albeit painful human responses to the difficulties of living as indicating mental disorders requiring medical intervention. It has achieved this in many ways. Next slide, please. But in particular through diagnostic manuals like DSM, which has rapidly expanded the number of mental disorders believed to exist, and which has progressively lowered the bar for what constitutes having a mental disorder, making it far easier for any of us to be classed as mentally ill. By expanding the definition of mental illness to encompass ever more domains of human experience, the sector has not only reconfigured how we respond to distress in healthcare settings, but how we respond to distress in the wider social world, whether we're looking at behavioral difficulties at school, underperformance at work, grief at a significant loss, the effects of unemployment, discrimination, abuse, trauma, poverty, social exclusion. These are just some of the manifold human phenomena now liable to psychiatric framing and psychotropic intervention. Such over-medicalization has, of course, been underwritten and promoted by the very industry set to benefit most from it. Next slide, please. The pharma industry, which has colluded with medicalization at every turn. After all, once widespread suffering has been medicalized and pathologized, then large swathes of the population must now be treated. And the treatments generally preferred in the neoliberal era have been psychopharmaceutical. And so this brings me to the next mechanism that has enabled our sector to thrive despite its poor outcomes. And this mechanism is commodification. Next slide, please. The process by which our sector has transfigured suffering into a vibrant economic opportunity. And of course, this opportunity has long been realized by the mental health sector, as the global market for psychiatric drugs, for example, next slide, is now worth in excess or approaching in excess of $40 billion a year. But let me give you one example of the link between medicalization and commodification by referring to one of the most influential documents in the NHS over the past 20 years. Next slide, which is this document, the PHQ-9. Why is this so powerful as a document? Well, it was used throughout primary care for about 15 years to help doctors determine whether or not a person is depressed, and if so, how severely. One of the main criticisms of this document, however, is that it sets the bar very low for having a form of depression for which a drug can be prescribed. And by the way, the data show that 85% of people who fill in these questionnaires do get prescribed psych drugs as a consequence. Now, what the tens of millions of people who filled in these and got prescribed drugs as a result almost certainly didn't know was that this document was developed by, its distribution throughout the NHS was paid for by, and its copyright was owned by, next slide please, Pfizer Pharmaceuticals, which incidentally makes two of the most prescribed anti-anxiety and antidepressant drugs in the UK, in the NHS. So in short, here we have a company setting the bar very low for what constitutes getting one of their drugs, but at the same time as making, selling and profiting from those drugs. And this has been going on in the NHS for many years. So this is just one example of how industry has promoted over-medicalization because in effect, it's created a vast market for its products. And we know of many other examples of funding key opinion leaders, funding research to facilitate the market, financial ties between DSM makers and industry being very, very common, etc., and so forth. So that's commodification. The current system is very economically profitable. But let's now move to another mechanism that has enabled the sector to thrive despite poor outcomes. And this is what I call depoliticization. Next slide, please. The process by which our mental health sector has conceptualized suffering in ways that protect the current economy from criticism. That is, reframing suffering as rooted in individual rather than in social causes, thus favoring self over social and economic reform. Since the 1980s, we've been increasingly moving away from viewing suffering as a protest against harmful circumstances that need to be addressed, which was kind of more popular view in the 60s and 70s under humanism, and moved towards conceptualizing suffering as an index of personal internal dysfunction that needs to be treated. And examples of such depoliticization are abundant in contemporary society. Just consider, for example, the rapid proliferation of mental health workplace consultancies over the last 10 years. Next slide. These semi-private professional companies that train selected employees within the workplace to identify other work colleagues who may be distressed and unproductive at work. Next slide. What this means in practice is referring underperforming colleagues to mental health services that reframe the characteristics typical of being dissatisfied and emotionally disengaged at work as symptoms of mental health conditions that require treatment. And by the way, we're currently in an epidemic of workplace dissatisfaction and disengagement. A lot of these experiences being reframed as mental health problems. There is no evidence that these consultancies actually improve employee mental health. Even so, they are very popular with employers, mostly because, and as I argue in Sedated, they help employers control the narrative about what causes workplace distress. By interpreting suffering as a commentary on self rather than system, they exonerate bad work conditions and meaningless work from causal responsibility. They also exonerate wider structural economic conditions that undermine the health of the working population, such as, next slide, please.
Just a 5-minute call, James.
Great.
Thank you.
Such as, they exonerate such as flatlining wages, rising wage inequality, increased short-termism in the employment market, the erosion of unionized working protections, longer working hours, growing pressure for dual working households, lower job security, higher job precarity, the rapid expansion of the service sector, to name a few. But such depoliticization of distress does not only permeate our workplaces. It colors every social institution where mental health tropes are now embedded. Just consider, for example, how the rise of behavioral diagnoses in our school children has been significantly fueled, I argue in the book, by the terrible pressures modern schools are under. While school resources are ever more depleted due to years of austerity, schools are simultaneously under ever greater pressure to deliver on a whole host of government-imposed outcome measures, being forced to succeed under growing financial duress. Schools have been leveraging mental illness labels to survive, as these win additional classroom funding and provision and give special allowances in Ofsted League tables. Or just consider how the mental illness narrative is being used to distract from key structural reasons for growing despondency and depression in our undergraduate population. Next slide. Research shows that a central reason why present-day undergraduates are far more depressed than in the past is because they sense they are entering a far less benevolent world, where there are now large student debts to repay, decreased prospects of owning a home, where the job market is more competitive, where wages are flatlining or decreasing, where careers for life are disappearing, and where levels of worker dissatisfaction are escalating. Despite the many obvious social determinants of higher despondency, the narrative around worsening student mental health is still mostly depoliticized. The cry is for more mental health services and mental health consultancies, not for serious reflection on and reform of the harmful social policies that have dampened students' hopes and dreams. This latter domain feels too big, too entrenched, so we instead focus on mental health away days, relaxation hours, and better access to GPs. So what should have been a national conversation about where neoliberal policy has corrosive emotional effects in our public sector, in our schools, in our workplaces, in our universities, in our communities, our families, and in our wider economy, instead becomes a conversation about the growing epidemic of mental illness in all these domains of modern life. A conversation often draped in sanctimonious and conspicuously pious calls for more mental health provision, less mental health stigma, that is, in ever louder calls for more of the failing same. I have only 1 minute left. I was going to talk about 2 more mechanisms, but I'm going to skip that for now. Could you move the slide on to the concluding slide? I think it's three slides from where we are. And next one, next. To conclude. Okay, to conclude, the mechanisms I've discussed, and there are many more, of course, I've just discussed 3, are mechanisms, I argue, that have helped align our mental health sector with the interests of neoliberalism. But I also argue that these mechanisms actually were never, in my view, purposefully plotted behind the scenes. The actual truth, I think, is kind of far less enticing, perhaps even more banal. Our mental health system has, like most other major social institutions, simply come to embrace those mechanisms that have best secured its own security and perpetuation. Our sector has become what it is and has continued to thrive and expand despite its poor outcomes, by moving with rather than by defying the dominant neoliberal tide. As Michel Foucault once put it, political power rewards those ideas and practices that best serve its own aims and interests. And so the ideas and interventions that have been funded and implemented are those that have ignited the ideological passions of the powerful, the ones that have medicalized, pathologized, depoliticized, commodified, individualized our emotional distress, the ones that have robbed our suffering of its capacity to illuminate social ills, galvanize social action, and facilitate lasting and meaningful personal and social change. 3 more sentences. Unfortunately, the outcome of this mutually beneficial alliance between neoliberalism and our sector has been ongoing poor outcomes, growing harms, and public disillusionment. So I think the time is here to do things differently. I think it's time for radical change. But I also think if change is to be given a chance, we must understand the socio-political context that has allowed bad philosophies, ideas, and practices to crowd out viable, effective, psychosocial, community-based provision that people need and want. And I just want to finish now with one final reflection. This argument for more demedicalized, a more demedicalized set of circumstances is not an argument for decreased provision. It's not a libertarian call for less state support for those in need. It's a call for more support, but support of a different nature. Support that places the call for social justice and inclusion at the heart of what we do. Thanks so much for listening.